Okay, let's get started. It's 7 p.m. Singapore time on the 1st of July. And on behalf of the SingHealth Duke-NUS Global Health Institute, I'm delighted to welcome all of you. This is a 5-part webinar series that we have put together. It focuses on the impact of COVID-19 on health and health inequities in the ASEAN region. As you're all aware, health systems across the world are kind of rife with health inequities that adversely impact different groups of people at all times. ASEAN countries are no different. And unfortunately, when health systems are faced with challenges as daunting as the current pandemic, vulnerable groups are even more impacted. This webinar and the following 4 webinars will explore this in greater detail. Today's session will provide an overview of the health inequities in the region, look at issues related to universal health coverage and how access to health systems has been compromised. The subsequent webinars will also focus on specific health topics, including maternal and child health, food security and nutrition, other infectious diseases like TB, HIV and malaria, and non-communicable diseases. The webinar series will explore possible interventions to mitigate the impact of this global health crisis in countries of the ASEAN region, and we are really excited to have a very wide range of perspectives and people from all over the region talking to these points. For today, our moderator is Professor John Lim, who is the policy lead for the Global Health Institute and the director for the Center for Regulatory Excellence at Duke-NUS. As always, Professor Lim wears many hats. He's also the chairman of the Consortium for Clinical Research and Innovations in Singapore, a senior advisor to Singapore's Ministry of Health, and a member of the board of the Singapore Food Agencies. In his current roles, he draws on his international experience and networks to enhance capacity building and scientific excellence for issues related to health product regulation, health policies, and health systems in Southeast Asia and Asia Pacific. I really look forward to the discussions, and I'll hand over to you now, John.
Thank you very much, Amina. And good evening, afternoon, and morning to our audience in Singapore, around Southeast Asia, and in other parts of the world. We're delighted you can join us as we begin this series of webinars, delving into the issue of how health and health inequities in Southeast Asia, or the ASEAN region, as we call it, have been impacted by COVID-19. Now, as the first session in the series, today's webinar aims to provide an overview of the healthcare systems and existing health inequities in the ASEAN region, and also the pandemic's impact on our populations and patients. This will set the stage for the subsequent sessions over the next 4 weeks that Amina has described, that will take deeper dives into maternal and child health, food security, nutrition, HIV/AIDS, TB and malaria, and finally non-communicable diseases. I'm delighted to be joined today by 5 distinguished and very experienced panelists who will speak from their country contexts of Thailand, Vietnam, Malaysia, Cambodia, and Singapore. And they will elaborate on how the COVID-19 pandemic has exposed and may even exacerbate existing inequalities in the health systems in and around our region. We look forward to hearing their views on the impact of the pandemic on healthcare access for marginalized and vulnerable groups in the region, challenges in achieving relevant sustainable development goals, as well as possible strategies to mitigate the negative consequences, not only now, but in the post-COVID new normal that we keep talking about. In the interests of time, we will not be taking live questions, as can usually happen through the Zoom Q&A function. But in the panel discussion at the end, we will attempt to answer those questions submitted as you registered, if they are not addressed during the presentations. I will now introduce the 5 speakers first, and then invite them to share their views. Our first speaker is Dr. Pia Hanvaravongchai, who is the Secretary General of the Thai National Health Foundation and Program Director of the Equity Initiative of the CMB Foundation based in Bangkok. He also teaches health economics and health systems at the Faculty of Medicine at the Chulalongkorn University. Pia has been active in health policy and systems research and development in Thailand and globally. He has consulted for the Global Health Workforce Alliance, WHO, the World Bank, and other regional and international organizations. Pia previously worked at the London School of Hygiene and Tropical Medicine, WHO, and Harvard University. Our second speaker, Dr. Chen Thi Mai Oan, has been the director of Vietnam's Health Strategy and Policy Institute, or HSPI, since 2013. The Institute's main functions are providing evidence for health policy development and playing consultative roles in health system development. As director of HSPI, Oan has been called upon to lead and support major transformational health initiatives and policies covering health system performance, health financing mechanisms, and more recently, health technology assessment and development of health benefit services packages to support implementation of universal health coverage in Vietnam. She has worked extensively with high-level policymakers and government leaders to make the most efficient use of evidence in health policy making in Vietnam. Our third speaker is Dr. Kaw Swee Keng, who is Senior Visiting Fellow at the United Nations University International Institute of Global Health in Malaysia. Swee Keng is a physician and health systems and policy specialist, currently on a sabbatical and reading public policy at the University of Oxford. Previously, he held progressively senior roles in clinical medicine, refugee and disaster relief, clinical research, and healthcare anti-corruption, covering more than 90 countries across Asia, Africa, Europe, and the Middle East. He has a medical degree from the National University of Malaysia, Masters in Public Health from the University of California, Berkeley, and he's a member of the Royal College of Physicians of the United Kingdom. Our fourth speaker is Dr. Kumanan Rasanathan, and he's Coordinator Health Systems in WHO's Cambodia office in Phnom Penh, where he leads the team on health systems and maternal and child health. Kumanan is a public health physician with 20 years experience in health and related sectors, a board member of Health Systems Global, and vice chair of the program working group for the 5th Global Symposium on Health Systems Research. He was previously with UNICEF, where he led work on implementation research for areas including essential child health services, universal health coverage, health systems resilience post-Ebola, and the Sustainable Development Goals agenda. He has also worked at WHO and has provided technical support to public health programs in over 25 countries. And last, but certainly not least, is Dr. Hisham Badaruddin, who is Adjunct Assistant Professor at the SingHealth Duke-NUS Global Health Institute, or SDGHI, and Director for Healthcare Deloitte Consulting Southeast Asia. Hisham is a public health specialist and a Fulbright scholar with over 20 years experience in senior level policy making and healthcare management. He was an emergency medicine physician in the UK and Brunei before pursuing public health and epidemiology. He served in the Ministries of Health of Brunei and Singapore, and also consulted for WHO, UNICEF, and ASEAN. His areas of focus include healthcare strategy and operations, health system strengthening, smart health and analytics with public healthcare providers, agencies, and international donors. So I'm sure you will agree we have a very distinguished panel with a vast range of experience, and they're very well positioned to address the issue this evening. And so without any further ado, I would first like to hand the time over to Pia to share his thoughts on today's topic. Over to you, Pia.
Thank you, John, and thank you, the organizers, for the opportunity to be here to join you all. I was asked to give a short, quick presentation on the situation in ASEAN and the impact of health, the impact of COVID-19 on health equity. And as you all know, we are in a region of about 650 million, about 8 to 9% of the world population. And we are in a region which is very diverse. The Lancet once called this region a microcosm of global health. We see very differences, many differences. If you look, for example, this is a statistic on Human Development Index in the Asian member states, and you see a big variations. But at the same time, we also see that many countries are catching up over time. This is a trend from 2000 to 2017. If we look at the next slide, in terms of the health, one indicator we could look at is the immunization. This is measles immunization rate among the 1-year-old children. And we also see the gap, but still we see the trend as well that is improving in most of the countries, and many countries are getting much better than before. One caution though is that even though we have a big improvement in many countries, this is a graph that shows under 5 mortality in some of the Asian countries that WHO has their data on health equity monitoring database. And they compare the poorest quintile, which is the 20% poorest if you rank all the people in the country, and with the richest quintile, which is in the purple color. If we only look at the average, we probably see the improving trend, child mortality reduced in almost all of the country. But one thing we probably could easily ignore is that the gap actually didn't reduce that much. And in some of the countries, actually the gap increased. And this is the background of the region in terms of the development that we have, but also need to be careful that inequality in income is just one of the dimensions of inequalities that can happen. There are probably other areas that we still need to improve. Then if we look next into the issue of COVID, we all probably have seen a lot of this over the past few months, the number of cases, the reported case. And can you imagine today we have 10 million already confirmed cases globally. And if we look in our region, we seem to be doing much better than the other region. Overall, we have altogether about 150,000 confirmed cases. And this is less than 1.5% of the global confirmed case. Of course, some of the countries may have questions about the degree of testing and how correct, but I think overall, generally, we seem to be doing pretty well in containing COVID-19, even though some countries may be better than the others. Yesterday, I was at a meeting actually, and one of the person in the meeting asked that, oh, maybe we could have some lessons to share with other countries about the achievement we have or the success we have. And I was thinking, well, we're still so early in this crisis or challenge. And I think there are actually a lot more than just the confirmed cases that we should look in terms of the impacts to the health and the health equity in the region. If we look at the pandemic, we usually see those numbers, morbidity, mortality, but the impact from COVID actually have many more dimensions than that. I put this as a triple threat from the pandemic. And the first one, of course, is the direct COVID-19 health system impacts. We see the dates, the number of people infected, and we seem to be quite well in the region to contain that in most of the countries. But there are also other health system impacts that arise from this pandemic, from both the need to shift resource to be responding to the pandemic. We need to adjust our health service system, and we have higher costs for universal precaution and other pandemic prevention. We also have both benefit from the public health measures and government response that came to contain the disease, but we also suffered also from its negative implications. In Thailand, for example, the partial lockdown, the social distancing or physical distancing measures help improve the outbreak, contain the outbreak. It also helped us reduce traffic accident, which is a positive side effect that we didn't expect. The number of communicable diseases also lower in some of those, like influenza and measles. But at the same time, there were also outbreaks that, the negative impacts that come from it, from the stress due to the lockdown, the disruption in health service, which I will talk next, and also other social and economic implications that arise from the interventions. We see a lot of people that are suffering from the loss of income, job loss, the number of people who don't have housing increase. We also see changing healthcare demands and potential access problem to healthcare services. At the societal level, the economic and social implication can also be vast, and we're still at the beginning of it. We may see increased inequality that is the result of increasing poverty we are facing, and the economic situation can be even more, especially in Thailand, for example, after the government support is ending. At the end of the last month, they gave out 5,000 per person for 3 months for most of the informal sector, but those are ending, and we are still unsure what the continuing economic implication would be. So if we look at the issue of the pandemic threats, I would emphasize, in addition to the morbidity and mortality problems, there are broader mental health issues that we are facing, which is a result of both direct COVID infection that happened to the patients, the families, the stress among the health workers, the people who already have mental health also are the high-risk group that will suffer more. The elderly who have difficulty accessing information, but at the same time, more likely to have chronic disease and more at risk of suffering from the consequences if they get infected. And people who get serious economic shock, who lose their job, who lose their income. And those are creating a lot of stress, anxiety, depression, and many of them also lead to suicide attempts. In Thailand, we see that the number of mental health hotline calls increased almost 2/3 in the first quarter, which was at the beginning. The statistic for the second quarter not come out yet, but we expect it to be higher. There are also 30% increase in suicide attempts, and more than 2,000 extra suicide deaths are expected throughout this year. And this is a big problem that we need to be aware and be prepared, as well as to try to prevent. The issue about health service disruption is also a major concern, as our history in the past pandemic told us. Many countries have difficulty maintaining routine health services. One recent study in the Lancet by Robertson and friends shared that among the low and middle income countries, we could see up to 10 to 19% reduction in EPI coverage or immunization coverage, more than 10% increase in wasting, and potentially 250,000 additional child deaths globally in the low and middle income. This is a big problem. And in Thailand, we seem to be somewhat lucky that we have a good health system, primary healthcare system, and universal coverage of health insurance. But those are not covering all of the population. There were some people who are left behind, for example, non-Thai migrant workers, or some of the people who are stateless or don't have a citizen ID card. We also have to be prepared for the outcomes of the system or health service adjustment that have been ongoing. As in many countries, many of the hospitals had to stop or reduce their services during the outbreak. And now they're resuming, but they still want to restrict or try to limit the number of patients that they can see each day. This means that because they want to avoid concentration, so this means that they have to adjust by both extending the follow-up time for the chronic cases. The people will need to come with a longer appointment, like for diabetes, you may need to come back in 4 or 5 months instead of 2 months for the uncomplicated case. Some try to use telemedicine, teleconsultation, which is a good initiative to try to improve care during this time. But there are also hospitals and healthcare centers that try to use outreach and village health volunteers and general practitioners to help with screening and primary medical care and to stop people from going straight to the secondary or tertiary hospitals. These are some positive adjustments that we can see, but there could also be potential cases that were left behind, some who were suffering from the quality of care that may not be adequate. And as of now, the early evidence show that we have about 6% decrease in inpatient admission during the month of March and April. And there were some reported access problem for some specific type of care, for example, reproductive health, some sexually transmitted infections testing or screening, and some of the, especially among the marginalized population or people who are suffering from some diseases, they have more difficulties. If we look at the impacts, we talk about mental health issues, we talk about the health service disruption, and many of these are basically impacting more among the people who are at the very disadvantaged position. We can expect to see widening health inequalities in many countries in the region, including Thailand. Over the past 2 months, when there was a lockdown, I think I've been very privileged actually to have a chance to spend time with my families at home. But many of the people didn't have that chance. This is a picture example of, on the left is Jota, who is an informal worker in Phuket in the tourism industry. But because he's a daily wage earner, he doesn't get social protection. And when there's not enough money to buy food and others, he decides to take all his family together on one motorbike to drive back to his hometown, which is many hundred kilometers away. On the right is another example, Mr. Meng and Mr. Norm, who's a non-Thai migrant worker working in Lopburi, which is in central Thailand. They lost their job, they don't have their income, they don't have their relatives. They have to walk almost 8 days, even though there were people supporting some food and giving them some money and helping them with some transport. But it was a gruesome experience. And we are seeing many of these people who are suffering, people who are left behind. And the vulnerable population or the marginalized population are at higher risk because they are both more likely to be exposed to the disease as well as the negative implication of the triple threat that I mentioned. They're also more vulnerable because they're usually at a lower nutritional level or not proper health situation. They're also more likely to be left out from the existing social protection scheme of social protection system. In Thailand, even though we have universal health insurance, we still don't have good or adequate coverage of a broader social protection, old age support or children's support. And the COVID-19 pandemic highlight many of these situations for us. We should try to continue what we have done well, try to improve the performance so that we can capture and try to protect people, improve the situation in terms of health equity that we are probably likely see is worsening over the next months and few months and few years to come. So I hope we all through these seminar sessions, we can identify more ways to basically both improve health, but also health equity in the region. Thank you.
Thank you very much, Pia, for a very comprehensive and very succinct but excellent overview of the issues in the region. I think the issues you've highlighted in the health system in Thailand actually resonate with all of us across different countries in Southeast Asia. I would now like to ask Dr. Uan from Vietnam to share your views and give us a perspective of what's happening in Vietnam. Vietnam has been regarded very highly in terms of managing cases and keeping the numbers low and down. And we'd like to hear from you about your thoughts on the impact of COVID-19 on health and health equities in your country. Over to you, please.
Okay, thank you very much. So I would like to share with you a story of Vietnam regarding country intervention in preventing COVID-19 and what are the COVID impacts on health and health equities in Vietnam. Firstly, the government of Vietnam has implemented different strategies to prevent COVID at the early stage with decisive actions. A National Steering Committee for COVID-19 control was established promptly and developed a multi-sectorial response plan, while many countries were debating their health and economic choices. But Vietnam's government made a decision to prioritize the health over economic growth. So we implement different strategies to prevent COVID, including the quarantine immediately on suspected cases, and also epidemic control, doing with the testing and contact tracing, and local authority also taking a 4-tier approach to contact tracing and isolations. For the public, they are well informed of personal protective measures. The Ministry of Health informed the public of positive cases and potential exposure and provide guidelines for disease prevention. The government provides timely, clear, transparent, and tailored information to the community to improve people awareness and understanding on the importance of their responsibility in preventing COVID. And this provided information, we realized that it will also provide help the people to avoid scare and depression due to COVID. When they have adequate information and with the correct information, so they are not so scared, and they follow with the method to prevent COVID, but not too scared to do it. For the people living in ethnic minority and mountainous area, we also have good strategy to provide a communication strategy to ethnic minority people in many different forms, such as through the system of communal radio station, or promoting the role of the people who have the strong voice in the community, or village elder and village head to visit household to provide information and guide them how to prevent COVID. And these communication document also translated into 25 ethnic minority languages to ensure that the ethnic minority people are able to access the information on the COVID prevention. So regarding to the to avoid impact of COVID on health and health equity issue in the health sector, we have done a number of things. The first one is that for those who suffer from existing disease, such as communicable and non-communicable disease, they are considered as the people at high risk with COVID-19. So the Ministry of Health required community health workers to visit households to deliver medicine and follow up their health at home and detect suspected cases in the community. People with hypertension are provided anti-hypertensive medicine at home. And also, in order to protect COVID patients from financial burden due to treatment of COVID, all treatment costs for COVID-19 are covered by health insurance scheme without co-payment policy and any extra payment from the out-pocket. So for the COVID patient, they don't have to pay anything at all. And for the older people and also people with NCD, we also provide service through the telemedicine with the support from hospital at central level. So the government set up a system so that the healthcare provider at central level can provide services and can give the consultation for the patient in the province or even in the commune, to show them how to cope with their disease and provide consultations through telemedicine. So as result, up to date, in Vietnam, now we have 355 COVID cases, and so far no one has died, and 95% of them were recovered. So with the remarkable achievement of Vietnam in preventing COVID, we draw 3 key lessons learned. The first one is that the commitment and determination of the country leaders is prerequisite for successful epidemic prevention. And the second one is that engagement of the entire political system and multi-stakeholders are very critical in preventing epidemic. And the last one it is that the responsibility of the health sector. With the existing system, we have good priority, setting priority in identifying the high-risk groups, so that we pay a lot of attention in taking care of them, because we think that they are the people who have a high risk of getting COVID. So the vulnerable groups need to be considered as a high-risk group and need to be put as a high priority in helping them to avoid the impact of COVID-19. So it is the case of Vietnam, and I would like to share with you on this. Thank you very much for the attention.
Thank you very much, Dr. On. It's very impressive, and I was struck by how proactive all the authorities as well as the population were in responding to this, and also how you were able to cover not only the cities but the rural areas. So thank you very much for that. I'd now like to ask Swee Keng to give us a perspective from Malaysia. And can you tell us a bit more about the COVID-19 situation there, and again address this issue of health and health equity in the Malaysian context? Swee Keng?
Thank you, John. John, allow me to take 1 second so that I can share my screen, and I'll just check that everybody can also see it. Right. Mariel, just to check with you, are you able to see my screen?
Yes, it's all good.
Thank you. Hello, everyone, and greetings from Malaysia. I enjoyed very much what my colleagues from Thailand and Vietnam have shared with us, and I'd like to bring the perspective of Malaysia. But before that, what I'd also like to do is to have a look at the title for our conversation today. And if we look at it, it says the impact of COVID-19 on health and health equity in the ASEAN region. What I'd like to do is to focus on migrants and refugees. Refugees because I worked with them for 6 years when I was in Malaysia. They were coming from Myanmar and Indonesia. And migrants because they are a very large population in the Southeast Asian region. What I will do is just to go through one slide. And in this one slide, there will be 3 components in the comments I will share with you today, focusing on migrants and on refugees in COVID and how COVID has affected the inequalities and, shall we say, the equity of health for these 2 populations. We'll begin with the box on the left in blue, where we'll look at some baseline information, and then we'll move on to the box in the middle in red, where it's accelerating inequality, or rather COVID is accelerating inequalities in several ways, and we'll dissect these ways through some of these bullet points. And then finally, we'll end with the box in green that looks at the recommendations of what the nation states within ASEAN can do to improve the health outcomes and also to improve the equity for health for migrants and refugees. So this is what we'll do over the next 4 minutes or so. Let's look at the box in blue. Baseline information is crucial for us to begin to understand the situation for migrants and refugees in Southeast Asia. I've gotten some data from the national agencies that are usually economic agencies or labor agencies or statistics agencies, also IOM or International Organization for Migration, or ILO, International Labor Organization, or the High Commissioner for Refugees. And I present these numbers to you. They are estimates, obviously, and we all know the problem with statistics that they can be helpful, but sometimes also not really accurately describing the picture. We see that Thailand has got the largest number of migrants in Southeast Asia, but it's 2.8 million migrants in Thailand out of a population of about 65 million, 93,000 refugees in Thailand, And the numbers are as such as well. I would not read the numbers out for you. Malaysia has 2.2 million migrants and 180,000 refugees. Singapore has 1.2 million migrants and almost no refugees. Myanmar has got no migrants, and it's difficult to estimate internally displaced people, which is a separate category that's different from refugees. And Indonesia, despite its size of 250 million people, only has about 100,000 migrants and only 13,000 refugees. So when you put in migrants and refugees, and we're not talking internally displaced people, we're not talking about, stateless people as well, the migrants and refugees in Southeast Asia comprise only about 1 to 1.2% of the entire ASEAN population. So they're very small. There are existing ASEAN frameworks that I think it's important for us to at least know that they exist. In 2007, there was a declaration on the protection and promotion of rights of migrant workers. The year after that, ASEAN started an annual ASEAN Forum on Migrant Labor. So this is considered a triangle. The triangle is between, nation states, ASEAN and the ASEAN Secretariat, and also the UN agencies, notably ILO, IOM, and UN Women, because a lot of the migrants inside Southeast Asia are comprising of women. And in 2017, the declaration was refreshed into a consensus on the promotion of the rights of migrant workers. These ASEAN frameworks are very useful in rhetoric terms, but you might imagine that the nation state in ASEAN, using the principles of non-interference and respect of sovereignty, a lot of decisions are made at the nation state level, which now moves us into the box in red. And the box in red proves that COVID is accelerating inequality. I will have to give you some very high level ideas of how it's accelerating inequality. And this will be some more generalizations, yeah? But these things are intuitive to all those people listening in today. Firstly, we look at the big bullet at the top. There is an impact to COVID in at least 3 ways. The first one is healthcare access is reduced. On the background, in the, as a baseline, the access to healthcare for migrants and refugees is already very low. But now with COVID, it can accelerate the inequality in terms of screening and treatment. Number 2, social determinants of health, especially housing and nutrition, will be impacted for migrants and refugees. And number 3, the economic rights for migrants and refugees are generally ignored anyway, but in COVID times, especially for healthcare funding, paid leave and working conditions will accelerate the inequalities for migrants and refugees. There are also unfortunately related issues. And on the second half of the box in red, there's xenophobia, there's disinformation and misinformation, and a lack of disease education tailored to local language and context. There is a lack of an all-of-government response in the sense that the health agencies, the security agencies, and the economic agencies, they might have conflicting policies. And this is when you look at the landscape of just one country, for example, Malaysia. The fourth related issue of how COVID can accelerate inequality is the presence of irregular migrant workers. Those numbers that are presented to you in the box in blue are actually official numbers. But in Malaysia, although the official number is 2.2 million migrant workers, some estimates lead us to mention that there are another, on top of the 2.2 million regular workers, there's another 2 to 6 million undocumented or irregular migrants in Malaysia. And that presents its entire set of new challenges as well. And as like my colleague from Thailand, Dr. Pia has mentioned, mental health as well as gender-based violence are crucial elements in how COVID can accelerate inequalities for migrants and refugees. Let me leave behind the box in red, right? Having examined how COVID can accelerate inequalities and inequities in health systems in ASEAN, let's look at recommendations. And I divide this arbitrarily into 2. The first one will be health specific. And I referenced Thailand as the first one all the way back in 2001. And congratulations to our Thai brothers and sisters. They've introduced health insurance to pay for healthcare for migrants, including undocumented migrants as far back as 2001. And this is an enlightened move that could be replicated by many countries in Southeast Asia. In Malaysia, and I've just learned in Vietnam as well, there is free testing and treatment, including for migrants, especially in Malaysia. And this principles of free testing and treatment can also be extrapolated to any Southeast Asian country with sizable migrant or refugee populations. Thirdly, civil societies need to participate. And here we're talking about NGOs and international organizations and multilateral agencies and development financial institutions all need to come together to, shall we say, advocate for or deliver services to migrants and to refugees. And finally, the fourth health-specific recommendation is to provide education for COVID in local language. And this will reduce barriers to accessing healthcare as well. Leaving aside the health-specific recommendations, let me end my conversation today with the political and social determinants of health. Improving housing is crucial. What I mean to say is what Singapore and Malaysia has done in order to improve the housing standards for all migrants in Malaysia and in Singapore is an important step not only for COVID, but for prevention of any infectious diseases now and in the future. The idea, secondly, of granting refugees the right to work is postulated to increase Malaysian GDP by up to $700 million annually. And this is a very important political move for us to expand the space for refugees and migrants, which may include Malaysia and Thailand having to regularize or provide amnesty to irregular or undocumented migrants within our borders. Finally, I think that COVID, and many of us believe that COVID is a unique opportunity not to be missed, that we can use now the public health angle, also the economic angle to increase the rights for migrants and refugees. Thanks very much for listening, everyone. Those are my set of thoughts about how COVID has accelerated the inequalities for migrants and refugees in Southeast Asia, ending with a set of recommendations that are health-related, but also regarding the political and social determinants of health. Prof Lim, over to you.
Thank you very much, Swee Keng, for highlighting a very important area of migrants and refugees. And I think your last point is an important one, because while they're very much hidden usually from normal view, I think COVID-19, although it's a terrible pandemic, actually highlights opportunities to address their specific conditions. So there's that phrase that we mustn't waste a good crisis. And I think it applies very much in our context here when we're thinking of looking at inequities and inequalities across the region. So thank you, Swee Keng. I'd now like to pass the time over to Kumanan. Can you tell us a bit more about the situation in Cambodia? And also, because you wear a WHO hat, could you tell us a bit more about the World Health Organization's perspectives on this issue of health and health equity, specifically in our part of the world? So over to you, Kumanan.
Thank you, Professor John, and thank you to Dr. Amina for the invitation to join this very interesting session on a very important topic. What is the impact of COVID-19 on not just health, but also health and equity in the ASEAN region? So I think the colleagues have already brought up many important points that, of course, I think resonate across our region, including here in Cambodia. So perhaps maybe I can just explain a little bit about what's happened with COVID here in Cambodia, and then maybe reflect on some of those issues around equity. So firstly, I think when we think of the impacts, immediately people think of the direct impacts of COVID, if you like, of the virus itself in terms of its health impacts. But then, as others have already alluded to, we also need to consider the broader impacts, including on other aspects of health and other health services, and then the socio-economic impacts, which with this pandemic we've seen globally are very dramatic. So here in Cambodia, in terms of the direct impact of COVID-19 on health and health inequity, so far it has not been great. So as with many other countries in the region, Cambodia has managed so far to manage the epidemic quite well. There have only been 141 cases to date, 40 women and 101 men, mostly imported from overseas, and the rest have all been linked to those imported cases epidemiologically. There's a sort of interesting age distribution because there are a lot of older cases, mainly linked to a tour group from France that had a large cluster. But there have been no deaths and there have been no healthcare worker infections. So the immediate health impact of COVID-19 itself so far and impact on health inequity has been limited. So then when we consider these broader impacts that I think Dr. Pierre explained very clearly, so far here in Cambodia, in terms of the data we have from the public health sector, the impact on health service utilization does not appear to have been great. The indicators for immunization, for maternal and child health in the public sector seem to have been maintained. And then in terms of the socio-economic impacts, whilst we're still collecting data, these are significant, as they are in many other countries in the region. Cambodia's sort of major sectors for the economy include tourism, include garment workers, include construction, foreign direct investment. All of those sectors have been significantly and drastically affected by COVID. So far, the socio-economic impacts on inequity have probably been much greater than the direct impact of the virus itself. But of course, as others have said, the pandemic is by no means over, and the country has taken this very seriously and continues to prepare and manage the outbreak, not at all thinking that the epidemic is over, but also continues to try and address some of these socio-economic impacts, which I'll discuss a little bit more soon. When we think about health inequity, there are a number of frameworks that are useful, and any sort of health problem, health issue, affects people differently on a number of axes. And that's what we need to consider when we consider how to intervene to reduce health inequities. And of course, leave no one behind is one of the central tenets of the Sustainable Development Goal agenda, which was informed by our contention that perhaps in the Millennium Development Goals, for all the dramatic progress we saw in the world, including this region, perhaps we didn't pay enough attention to inequity. So there are 5 axes I'd like to highlight. So firstly, it's the socio-economic position that people are in. And so according to socio-economic position or other social determinants of health, a particular issue manifests itself differently, and COVID is no exception. But then there are also differences in exposure to, in this case, the virus, differences in vulnerabilities, differences in the health outcomes, as we've discussed, and also differences in the consequences of getting sick. So we need to consider all of these axes when we consider both the production of health inequities, but also how to intervene to minimize them. We also need to consider the pattern of inequality. So a country like Cambodia, which is 77% rural, one of the most rural countries in ASEAN still, even though urbanization is increasing, and it's a lower middle income country, recently graduated. So whilst there are marginalized groups, of course, there are those issues around education level and urban-rural split, issues around gender, sex disaggregated inequities, issues around income inequities. If you look at the sort of poorest 4 quintiles, they're relatively similar on a global sense to each other. None of those poorest 4 quintiles are rich by any global sense, although there has been dramatic progress recently. And wealth is relatively concentrated in the richest quintile. Other countries in the region perhaps have more of a concentration of deprivation. So what it means for Cambodia is a strong, comprehensive general response is very important of itself, is likely to be more equitable. And a response that reaches most of the population is going to reach many of the poorer groups. So then, if we keep those in mind, some specific sort of features that we've seen already in Cambodia, and the government has taken equity seriously and has put in place a number of measures to protect people from inequity. So last week we saw the launch of a cash transfer scheme for the poorest quintile, for those with a health equity card, ID poor, to buffer from some of this economic impacts of COVID. Secondly, treatment of COVID has been free. All services through the continuum has been free for all Cambodians. And in fact, for most of the epidemic has been free for everyone, regardless of their citizenship. So many foreigners have benefited from free care for COVID in Cambodia. That policy for foreigners has changed more recently to be more in line with other countries in the region, but care remains free for all Cambodians. Efforts have also been put in place to address stigma, to ensure that particular communities who have clusters of COVID are not marginalized or stigmatized further. And that's important. For example, we had one cluster around a religious gathering imported from another ASEAN country, and efforts were put in place to make sure that that community, which was a minority, wasn't further stigmatized. The government also didn't put in place a full lockdown, as with some other countries, taking into account the large informal sector worker and the impact of a full lockdown would mean on livelihoods. And so far, that has been successful. So they've balanced the public health benefits with the social and economic implications, of course, using a sort of risk-informed approach. So many good things have happened. If I can finish then with some of the challenges, and one thing that we don't have is perhaps enough real-time data on some of the broader impacts and impacts of inequity. One of the challenges of equity, of course, is that you need good disaggregated data. And Cambodia, for that type of data, as with many other countries, is mostly dependent on surveys that happen often every few years. One challenge is there's a lack of data on service delivery in the private sector, and a lot of health services are delivered in the private sector in Cambodia. So that could be a challenge, as we know that, especially at the beginning, many private clinics closed. Secondly, the border closure means that people can't access care in neighboring countries like Thailand and Vietnam for services that are not easily available in Cambodia, such as for some non-communicable diseases. So we don't have good data on what that foregone care has meant. And that's not just the wealthy. A lot of the middle class also do that, and people who live in border areas. Swee King has already mentioned the issue around migrants and refugees. And so almost 100,000 migrants have returned from Thailand, and measures have been put in place to screen for COVID, but there's also a lot of measures that have started to be put in place to address their social needs. And then there are the broader challenges around the economic disruption that may be manifested. Stunting is a big challenge in Cambodia, a major driver of health inequity. So it impacts on nutrition, impacts on gender-based violence, mental health, the inequitable impact of schooling closure. So schools have been closed here since mid-March and continue to be closed. And of course, those closures manifest very differently in two ways. Firstly, because online schooling, there is also televised classes. Often it's the wealthier who are best able to take advantage of those classes. Education is also a major ladder of opportunity for social mobility. So having it up to a year out of schooling has a much greater impact on the poor than the wealthy. And then of course, as schools are opened, it may be that wealthier schools are better able to meet the criteria to safely open in terms of class size and hygiene. But finally, I'd like to say, Cambodia has made such impressive progress recently, including on equity, closing gaps in terms of access to health services between the richest and poorest quintiles, and also progress on catastrophic expenditure by looking at reducing the issues around access in terms of financial risk protection. And the trajectory of that was very optimistic towards universal health coverage, to broader social protection, to poverty reduction. And given the changes in the fiscal outlook, that might be the greatest impact on health inequity if we don't have a massive outbreak here, which is possible but not guaranteed, and that some of that progress may be delayed. So I think there's still a lot to do. The government is very aware of that. And I think it's important that we continue to share lessons so that countries in ASEAN can share experiences and keep this focused on the worst off, on marginalized communities, to make sure that the COVID impacts are not just exacerbate health, but they don't exacerbate health inequities. Thank you.
Thank you very much, Kumanan, for highlighting these very significant socio-economic perspectives, which I think are very significant in terms of issues of sustainability when we look in terms of solutioning going forward from the current COVID situation. With that, I would like to pass the time over to Hisham to sort of, in a sense, well, not necessarily round up. If you can draw some strands together as you share your views, that would be very helpful. Hisham, over to you.
Thank you, John. Thank you, everyone, and my fellow panelists for providing such great insights into the situation in ASEAN and also their own countries. In Singapore, I think, at one point in time, at the start of the outbreak, we were even praised by international organizations, looked at other countries as a model country for the control and the response to COVID-19. I think that has been a result of great work that has been put in, a lot of effort that has been placed over many years by the Ministry of Health and many other agencies and government organizations and ministries. However, as you know, most of the participants are actually from Singapore. We have a situation where the outbreak has, kind of spread in a vulnerable population, and and that has caused our numbers to creep up. Admittedly, most of those cases can be said as being, well and not and stable. But then we have to think about, how did this happen, right? So the question that we need to ask is, what is there data? Is there indicators that we could have looked at in order to address where the gaps are in Singapore? Okay, because you're only as strong as your weakest link, right? If you're a chain, you're only as strong as your weakest link. So I know that many of us have looked at the outbreaks in the foreign worker dormitories and looked at how did this happen and things like that. But I think what we need to do now is actually look at that, learn from that, and then move on and make it better. I think Singapore has a role to play to actually kind of learn from it and teach other countries on how health inequities, which is happening right now in Singapore, can actually affect the whole response. So it's not just foreign workers, right, that are affected. As as Pia said, the economy is affected, and you hear of many people being laid off or unable to find work, and or having to take reduced pay. And this affects actually a substantial number of those freelancers, the gig workers, taxi drivers, and everything else. Those who are actually in the lower income, okay? And because they are the lower income, there is this link with lower income and lower health outcomes, right? Lower health status. So that it'll be good to actually look at that and then see how we can actually improve the healthcare system as a whole, to address that, not only in times of pandemics, but actually help it to look at that data and then see whether it impacts them in the long term, and see if that we can strengthen the whole healthcare system as a result of that. Okay, so there are other people like elderly, who and nursing homes who have been affected, homeless people, and of course special needs, right? So and I know that there's disruption to care and things and so on and so forth. I spent a lot of my years at the Ministry of Health writing preparedness plans and developing preparedness plans. And I must say that every outbreak, every epidemic, you learn something new and you strengthen your plans. And I think this is the time where we can actually help to strengthen those plans. But what I also wanted to say was that it's also a time to look at ASEAN and what ASEAN can do as a grouping to further help each other, right? ASEAN as a group, you have sovereign rights for each country, but for ASEAN, it's more a coordinating body. It's more they are actually platforms within ASEAN that can be utilized pre-pandemic, during the pandemic, and post-pandemic, right? So the ASEAN does have a role to play, and I think in a way we need to engage. ASEAN needs to engage countries and academics and the healthcare fraternity to look at how it can actually improve in terms of the response. Not only in the vulnerable groups, but also in terms of actually sharing best practices, sharing perhaps stockpiling, common stockpiling, and so on and so forth. So, and this is also related in a way to all the kind of bilateral border health agreements that we have. So one of the, as people would note, in Singapore, there were land border closures, which affected many people who actually travel every day from Malaysia to Singapore, and that actually created, some a mini crisis in itself, okay, over a few days. So I think, in terms of coming out of this pandemic, I think we all have to basically not hide the fact that there are vulnerable groups and health inequities in Singapore. We have to address that, be brave and actually face that. We know it exists, but use that opportunity to actually make it better and make that data better. Make that data available or collect that data and do the studies to actually help improve those the healthcare system overall. I think that's something that we definitely need to do, in Singapore. So John, it's very short because I wanted to give. I know it's 8 p.m. already, and I wanted to give time to answer for the panel to answer the questions.
Thank you very much, Hisham. Well, in fact, I don't think we have much time to answer the questions, and looking at what was submitted, most have been covered, but I would like to round off this session in a sense by picking up the last point that Hisham has raised, or one of the last points about, given this context of health inequities, and given the COVID-19 situation, how do the panelists assess the state of response of ASEAN as a region rather than the specific country context that you've been describing largely over the course of the last 1 hour? And picking up some of the platforms in ASEAN that Hisham referred to, what more can be done? Because as several have already said, we're still in the very early stages as the pandemic begins to develop and grow. And this issue of channeling a lot of resources, which has been very commendable in terms of using government resources to address the vulnerable populations within our respective countries. How sustainable is this going to be because of the huge socio-economic impact, especially the economic impact that we're facing across the region and globally? So Hisham, I'm going to go backwards and end up with Pia. Is there anything more you want to respond to in terms of these specific questions? Before I go back to Kumanan and back all the way through to Pia. Hisham. Sorry, we can't hear you.
I apologize. So within ASEAN, there's the healthcare cluster, or what they call cluster 2. And they have the various different platforms like your operations, your communicable diseases, field epidemiology, and so on and so forth. So I think in a way, but that's the technical level. What needs to be done is more an overall kind of like senior officers, and then that leadership commitment to actually say we need to work together to kind of like prepare for the next big one, because there will be a next big one, so far I think we've done well because we've learned from lessons from SARS and Nipah and everything else, but I think we need to strengthen ourselves a lot better, because the thing is, as I mentioned, you're only as strong as your weakest link in the region.
Thanks, Hisham. Kumanan, could I have your views on this as well? Regional approaches to addressing these problems across ASEAN.
Well, I think firstly, a regional and even the global approach is very important, because as our DG says, no country is safe unless every country is safe. And as Dr. Hisham just pointed out, nobody in the community is safe unless everyone in the community is safe. That's the only way we're going to tackle COVID-19. And so equity has to be at the heart of our efforts, not just as a luxury, but not just because it's the right thing to do, it's the moral thing to do, but because it's also the effective thing to do, right? So I think regional platforms are very important. Obviously, as WHO, that's one of our jobs. And one thing that's been very heartening, there are regular WIPRO and then the Southeast Asian Regional Office host sort of hookups between ministers, between the directors and ministries of health, And there's high levels of interest. There are global ministerial meetings, and people are very interested. The level of attendance interest in that is really impressive. And I think we need to keep doing that. Within the Mekong region, there's exchange between the different countries in the Mekong region, which of course traverse 2 WHO regions. In ASEAN, we've seen a lot of activity. We recently saw the ASEAN, the foreign ministers meeting, the heads of states meeting. So I think there's a lot, the region is getting together. And so I think that needs to continue. One area that particularly is challenging is now that we move to this chronic phase of the epidemic, which may go on for a year or even longer, is how do you balance the economic and the public health? And actually earlier this afternoon in this epidemic of webinars, I was on a ADB webinar, a dialogue across the region, looking at exactly this and saying that there've already been those discussions about how does the region come together on common standards around testing, around corridors for economic, for trade, even tourism for travel. At the moment, of course, countries have their national sovereignty, and there is a tendency in a crisis, you want to get everything in place well. Now that countries have put in place quite a lot, I think there's more scope to use those regional mechanisms, there are other mechanisms, to really get a harmonized approach and think how the region together can address a lot of those socio-economic challenges which are particularly difficult and certainly cross-border and certainly regional and global.
Thank you, Kumaran. Swee King, do you have anything to add to that?
Thank you, Prof Lim. I do. The rhetoric surrounding, I guess, regionalization of ASEAN efforts, health system strengthening, health systems capacity sharing, and so on and so forth, I think is very welcome. Now is the time for us to put the political will behind it and actually get this done. Some of the infrastructure that's available to us that Kumaran has actually raised, I think needs to be accelerated. And I bring the example in today's news that the United States has purchased 3 months worth of supply of remdesivir, leaving nothing behind for the rest of the world. Now, the efficacy of remdesivir aside, I'm not going to talk about that, but the idea that ASEAN countries individually, not even Indonesia, is large enough, geopolitically, financially, diplomatically, economically, health systems-wise, to, shall we say, work in a world that's increasingly nationalist. There's an increasing need for us to band together because larger size will give us more purchasing power, more diplomatic heft, more geopolitical, shall we say, sway when it comes to the global public goods that we really need to get into our region, things like vaccines and therapeutics and also diagnostics. So there's a need for greater political will, and I might end on that note. Thank you, Prof Lim.
Thank you, Swee King. Dr. Oan, what are your thoughts on the regional response to dealing with health and health inequities across ASEAN?
Yeah, regarding to the response of the regional to the Asian country, I think that the sharing experience between the country, it is very important because despite each country, we have our own situation, but learning from other, it is very important. It is not only on sharing on the intervention, but also sharing with the challenges we have. So how to deal with the challenges? Because like in Vietnam now, even we are success, but we think that it's just only the beginning of the situation, and we hope that there will be no more cases. But if there will be more cases, of course we will have to face with many challenges. So the first thing is that sharing country experience on that, and in the second things, in order to prepare for the pandemic. I think now it's COVID-19, but like in Vietnam, it is already the pandemic, but when we have more cases, so what we need to prepare, I mean, in the area of health sector, when we have more cases, how the hospital need to be responsible for that, and even in the other primary healthcare level, what is the role of the health facility at the grassroots level? It does not mean it does not only talking about the treatment in the hospital for the severe cases, but for the mild cases, what should be the capacity of the primary healthcare should be, so that we can deal with the pandemic with the involvement of the different type of health facility. So we need to such kind of technical support, technical sharing on how to prepare in terms of the human resources and including the equipment and infrastructure to deal with the COVID-19 when the pandemic is become more spread in the coming times. So it is some thoughts from myself.
Thank you very much, Dr. Orn. And can I ask Pia, you started us off, can you wrap up the session and give us your thoughts from a regional perspective, the response to this issue of health inequity, and the COVID-19 pandemic?
Yeah, thank you, John. I think it was excellent listening and learning from our panelists. And I think on the issue about ASEAN, I think I totally agree with Hisham and also Sri King that even though we have done quite well, there are a lot of opportunities that we could benefit from working together and coordinate better and stronger. There are probably a lot of some limitation because of the nature of ASEAN, how it's formed, the political structure. But at least I think initially we could try to move health higher on the agenda of ASEAN. Right now, the focus is mainly on economics, a little bit on security and others. But health usually, and not just health, probably we talk about social determinants. So social issues in general need to be highlighted and emphasized. And I think COVID-19 pandemic is a great opportunity that we will try to move this. There are many, many potential benefits. We can all work together and try to learn, improve, and help each other to achieve better development in the whole region. And that's, I think, my thought, and thank you for the session. Yeah.
Thank you very much, Pia. And I think picking up on your last point, in fact, this webinar has been a kind of mini attempt to look across the region, to share what has been happening in the countries, and also begin together to look at the solutions in response to all the issues that have been surfaced by COVID-19, not just in the health sector and the health of our populations, but in the economic sectors as well. So as we said at the very beginning, this is really meant to be, in a sense, setting the context for the subsequent 4 sessions when there are deeper dives. I'd like very much to thank Pia, Orn, Swee Keng, Kumanan, and Hisham. And with that, I would like to pass the time back to Amina to close off our webinar today. Over to you, Amina.
All I want to say is to add to your thanks thank you to you, John, for moderating it, and to each and every one of the speakers. I thought that was an excellent session to learn some very specific things of the countries, but also have a kind of regional perspective to it. So I can just say thank you all, and to the participants, I hope you kind of learned something from this, and please look out for our follow-up webinar registration links, which we'll be sending. I think the second one we've already sent, and we'll be sending out the subsequent ones. So with that, I will say bye-bye, and it was great to speak with all of you.
Bye-bye.
Bye.
Bye.
Thank you. Bye-bye.
Thank you.
Bye-bye, Pierre.